Welcome to the Mayo Clinic Ophthalmology Podcast, brought to you by Mayo Clinic. I'm your host, Dr. Andrea Tooley.
And I'm Dr. Eric Bothan. We're here to bring you the latest and greatest in ophthalmology, medicine, and more.
Today we are joined by Dr. Eric Kim, a pediatric ophthalmologist, adult strabismus specialist, and ant-seg specialist, to teach us all things about keratoconus, newest updates, and what you need to know.
Dr. Eric Kim is our guest today on the podcast, and he is not only a wonderful colleague of mine, he is a pediatric ophthalmologist here at the Mayo Clinic with expertise in pediatric cornea, glaucoma, and cataract, in addition to all the rest of things he manages in terms of pediatric strabismus. Dr. Kim was trained at the Baylor College of Medicine, followed by his fellowship here at the Mayo Clinic, and then additionally an apprenticeship in pediatric cornea, cataract, and glaucoma surgery at Children's Hospital, Los Angeles. In addition to his clinical activities, which I love sharing with him next door in the clinic, he enjoys teaching medical students, residents, and fellows. So with that delightful introduction, I get to say thank you to my friend and colleague, Dr. Kim, for coming on the podcast.
Welcome, Dr. Kim.
Thank you for inviting me.
Well, we're so happy that you're here to teach us all things about ant-seg in kids and adults. And before we kind of get started on the pathology side of things, I'd love to just hear about your kind of clinical trajectory. How did you get to where you are? Why pediatric ophthalmology? Why pediatric ant-seg specifically? Kind of tell us your whole journey.
You know, I think as with many of us, it was just a mix of good fortune and chance. Earlier on in medical school, one of my first rotations was in pediatric ophthalmology, and I worked with Dr. Steinkühler in Houston, Texas. And he was a remarkable man in terms of not just knowledge and skill, but his demeanor. He was an old, gentle soul, very kind-hearted, compassionate, and that really made an imprint on me. And so as I learned more about the field, I learned it was a good fit for me. I'm very OCD and detail-oriented, so I think it's nice to dive into a single organ system and learn everything you can about it. And I've always loved working with kids. You know, I just, enjoy talking with them and enjoying their imagination. And, basically I get to play with kids all day at work. So it's a great fit for me.
That's fantastic.
One of the unique things about pediatric ophthalmologists is that we practice in eye care and get to manage most every presentation that comes in. And we may draw in the oculoplastic specialists like you, Andrea, but certainly we're the home to a wide variety of conditions, because even if they go off and have lid surgery or retina care, they get to come back. And so we always consider ourselves broad in our skill sets. And yet I've appreciated Dr. Kim's additional training and passion in peds cornea, because there is a level of nervousness and concern and just management expertise that having that additional care he's brought to our practice, and certainly it's just been a compliment in what we do together. You did an additional time in pediatric cornea and glaucoma along with some cataract. Why did you choose that additional piece? What drew you to ant-seg in particular? You talk about your mentor, but most of us go, I don't want to deal with another corneal ulcer. And it fuels you. Share a little bit about that.
You know, I think earlier in my training, I was a little torn because I had that love for kids that was undeniable, but I was drawn more towards anterior segment disease and surgery and pathology. And so I feel lucky to have kind of settled on this space where I could do both. During fellowship, I got excellent experience in pediatric cataract, but wanted to supplement more with cornea and glaucoma skills and knowledge. So was really fortunate to be able to do that in Los Angeles. And I feel thankful that we have the ability to help these kids. Oftentimes this is they get kind of lost in the cracks. They need cornea or glaucoma care, but sometimes adult providers don't have that comfort with young kids, let alone toddlers and infants. So it's nice to be able to bridge that gap.
Yeah, I think that's fantastic, and we're so lucky to have you here. One of the things that is kind of in your specialty wheelhouse that we wanted to talk about today so that you can teach us all the things that enlighten us is keratoconus. and you are an expert in keratoconus, especially in kids. So start us off just for the comprehensive ophthalmologist who doesn't see a lot of keratoconus, or for a subspecialist like me, I'm very uncomfortable with keratoconus. What is keratoconus? What are we looking for? Kind of give me all the basics.
We all have learned about keratoconus in our training, but just as a quick refresher, it is a condition in which the cornea assumes a conical shape due to thinning and protrusion. Maybe an oversimplification is thinking of it like a beer belly. There's a part of the cornea that pooches outward. It's ectatic, it's thin, it's elevated, it's more curved. It is a non-inflammatory, bilateral, but often asymmetric condition. And the cone is often just inferior to center. Its incidence and prevalence has been debated in different studies. Historically, it's been thought of as a rare condition. A really nice population-based study based out of here at Mayo Clinic found that the incidence in a U.S. population was about 2.5 cases per 100,000 people per year. And yet, other populations might have a greater incidence and prevalence. Studies out of the Middle East have shown that it can be up to 1 in 2,000. And certainly in certain populations or demographics like children with Down syndrome, trisomy 21, it's known to have a prevalence of up to even 15% in those populations. So it can vary widely, and it can be quite significant in certain populations.
Wow.
So I think many of us, especially when I think back at residency, you were on the corneal service, and we saw very advanced keratoconus, people necessitating corneal grafts and management after chronic use with hard contacts. And they had classic features of a cone that was thinning, all the different slit lamp details we found. But I've been struck and humbled by how pediatric keratoconus is a little harder to catch, or because by the time you get those dramatic features, it's probably a much more advanced disease state. So share with us, as you think about adult versus peds, what makes pediatric anterior segment keratoconus management different? What do you look for? What do you think about? How do you? What are your thoughts that way?
Right. So I think first I want to comment on what you just said. How when it's at an advanced stage, it's pretty obvious. We all remember Munson's sign, or if the cornea is super cone-shaped, it's a medical student could diagnose it. But in today's day and age, the name of the game is to diagnose it hopefully before those overt clinical signs, and hopefully before the onset of loss of vision. In kids versus adults, it's generally a faster progressing disease. It often presents at a more severe stage. Studies have shown that a higher percentage end up needing PKPs. So I think, especially in kids, one needs to be on higher alert.
Maybe I should know this, but I mean, if it's a progressive condition, but is it always happening in childhood, or can it happen later in life when we're thinking about when we want to catch it? Like, when is that optimal screening happening, or can it be at different times for different people? Like, is it when they have a certain amount of astigmatism we need to be checking for it, or how do you diagnose it when it's not obvious on exam, or is there an age cutoff that we need to be thinking about?
So I think the book teaching has been, it presents in kind of early adulthood, or maybe a little earlier, like puberty. I think, as I said earlier, since we're trying to catch it earlier, I think we're looking earlier too. So yeah.
Okay.
So one of the things I've been struck by, and you've helped to guide our section along, is sort of the radar of when to start thinking about, maybe this could be keratoconus. So it's certainly true that an 18-year-old or a 25-year-old maybe have progressive findings, but as you're suggesting, is it there earlier? So what would be, in a basic eye exam, lacking corneal features of scarring or striae or but in a refractive error, what would you want people to look for and think this could be keratoconus?
So I think that's the $1 million question of when exactly should we take the next step? What finding, what level of astigmatism or refractive error should trigger getting a corneal tomography, for example? You know, I think we don't know yet. You know, some studies have proposed astigmatism greater than, say, 3 diopters, maybe screen all kids at that level. But there's no consensus. There's, you know, small studies of different populations that are hard to extrapolate. But for myself, I try to look at a few different factors. One is history, right? And does a child report or the family report that there's a lot of eye rubbing happening, habitual eye rubbing? And then I always assess the child's sort of overall health. You know, are there any other systemic conditions that may be related, like atopy or trisomy 21? We've talked about being a risk factor. Really, any developmental delay has been shown to be a risk factor. Sleep apnea, conditions like Ehlers-Danlos or Marfan syndrome have been implicated as well. Going to eye associations, certainly habitual eye rubbing, whether it's from allergies or other reasons. Floppy lids, if the lids are really floppy on exam, I make note of that. Vernal keratoconus conjunctivitis and contact lens wear, I keep in mind. And then, you know, on exam, again, we're hoping to catch it before overt clinical signs, but maybe one eye is showing signs that are more obvious and the other ones are more subtle. Maybe the beginnings of a Fleischer ring, maybe slight Vogt striae. On retinoscopy, there can be an irregularity of the light red reflex that can be a sign. And going back to the refraction question, if, you know, a healthy child should otherwise be able to refract to 20/20. So if they have not been able to, if we cannot, that's unusual. If there's a history of high or increasing myopia or astigmatism, again, it's hard for me to give exact cutoff numbers, but certainly the higher, the faster increasing is the more suspicious. And if there's changes over time or an irregular axis, you know, kids are usually with the roll, but does a child have an oblique axis or against the roll? That might be something to take note of. But really, the most important thing I would like to share with our audience is that in today's day and age, corneal tomography is really essential, you know, more than topography, because you're looking at the corneal curvature, both the anterior and posterior side, and that can be the earliest signs of keratoconus. You know, we're looking for subclinical keratoconus at this point.
That's a great overview.
It
really,
is.
really good.
And that's sorry. It's like I've definitely come out of my clinic and said, Eric, should I do imaging on this cornea? And even though commonly we think of conditions that have those structural abnormalities or systemic associations, for me it's the +4 cylinder in a new patient, and I don't know the history. You know, if it was a baby that grew up from the NICU and I've always seen high amounts of cylinder, I might not worry as much. But so often it's a new patient after failed vision screening at school, and they're 6 years old, and they have +3.5 cyl. And my first thought is, oh, maybe I need to check. And so it's been a great resource in doing that. So your encouragement would be to have a low threshold with unusual astigmatism, unusual progression or associated findings. So, and when you order that, what do you specify? Because I know how I've ordered it and looked at it sometimes. The scans aren't always as clear-cut or helpful as the way you've done it. So share with us, when you get a pentacam, how do you order it, and what do you do, and what do you look for?
On the pentacam, there's a few maps I like to look at. One is the curvature, the axial curvature, and we all know the classic inferior steepening. There's often a reciprocal superior flattening, and I look at the magnitude as well. Again, there's been different indices that have been reported. Corneal curvature above this amount should be a warning sign. I also like to look at the pattern of the astigmatism. Is it just regular withdrawal astigmatism that's on the higher side with a nice symmetric bow tie? Or is it an asymmetric bow tie with skewing of the radial axes at a weird angle that's more inferiorly than superior? I like to look at the pachymetry map as well. Is a little thinner than usual, and is a thin spot decentered. I also pay attention to the anterior and posterior elevation maps, and try to see if there's any islands of elevation. You know, and again, there's different cutoffs. You know, some people reported more than 10 microns for the anterior float and maybe 21, 22 for the posterior float, like an area that's higher than the rest. And certainly if all those findings I mentioned are at the same spot or coincident, that to me is more convincing. And going on that, certainly if there's all those things, super high curvature, it can be a slam dunk diagnosis. But going back to what we said earlier about the goal trying to catch it earlier and earlier, most people agree that the earliest signs are at the posterior curvature, which is why I share that a corneal tomography may be much more useful than topography, which only looks at the anterior curvature. So there are scenarios where on the curvature, there's no obvious inferior steepening, the Ks look pretty unremarkable, the corneal pachymetry is normal thickness, and even the anterior curvature looks, bland, normal. But on the posterior map, you might begin to see the startings of a little island of elevation, a little area that looks suspicious. So that should prompt at least monitoring and surveillance with additional scans over time.
If certainly if the features are concerning, as you've articulated well, things to look for, you're going to be monitoring more often, you're going to be maybe referring. If you get a scan in a kid that's a failed vision screening in a person's office and it ends up looking like routine, beautiful bow tie, regular astigmatism, do you need to repeat scan over time, and image again 6 months or a year later, or can one be enough to rule it out, and then as long as you follow them clinically and give them glasses and aren't alarmed, is that sufficient? So we're going to talk about the ones that are disease positive next, but the ones that you sort of rule out, is it okay to not scan them again?
It's hard, I think, to give a complete black and white yes or absolutely no. Maybe if some well-powered studies come out with big numbers, maybe we can really hang our hat on certain cutoffs. For me, I try to treat each case individually and look at the big picture. As you refer to, if it's a otherwise healthy kid and the astigmatism wasn't that high to begin with and no other risk factors, then sure, maybe it's, not imperative to repeat the scan. On the flip side, if it's a kid who is literally rubbing his or her eye on the chair in front of me, has eczema, sniffly nose, contact lens wearer, and there are more than one suspicious signs on the Penacam, the astigmatism's on the higher side, then I would probably rescan.
Yeah. Okay.
And somewhere from 3 to 6 to 12 months, depending on how worried I am.
Mm-hmm. That all makes sense. And so you've mentioned multiple times how important catching these early changes are. And is that because it has direct influence on treatment and options that we can give these patients?
Yeah, I think it's because really of corneal crosslinking that has become available to us as a tool. That's really changed the game. Before that, I suppose you're just hoping for the best and, treat with glasses, and when that fails, contact lenses, and hope the patient doesn't get eye drops and necessitates a corneal transplant. But now we have a treatment in our toolbox that can halt or at least slow the progression of disease, and hopefully stave off eye drops and the need for transplants. It's been available for many, many years now, and there's been studies showing even the cost effectiveness of this intervention if you consider loss of productivity and costs associated with bigger surgeries like transplants. And so I think that really is driving our search to catch and treat and stabilize these patients earlier.
That's Terrific. And I don't know a lot about crosslinking. I would love a crosslinking overview for beginners. Like, give me the first year resident level crosslinking overview.
So crosslinking has been around for a while. The first reported use, to my knowledge, was around 2003, and it was FDA approved in 2016 with the traditional Dresden protocol epithelial off technique. This is a procedure where you treat the cornea with riboflavin, usually in a solution form, and you apply UV energy to the cornea to create a reaction where the collagen fibers of the cornea cross-link and become stiffer and stronger and hopefully slow down the rate of progression of this disease.
It's a long process. So when you, at least when I've shared a case or two with our colleagues before Eric and now since Eric's time here, I've just been humbled by the commitment that it takes to do this for children. You sedate them for how long would be an average cross-linking?
Well, in the U.S., currently we only have one option. It's with the Glaukos company's platform. And again, it's the epi-off protocol where you have to remove the corneal epithelium to allow the riboflavin to soak properly throughout the cornea.
Mm-hmm.
And
is it reapplied throughout sedation, like for 45 minutes, isn't it?
That's correct. So
the solution is?
Yeah.
Okay.
There's
it's a really patient.
There's a soaking step for 30 minutes. So backing up, the first step is to remove the corneal epithelium.
Is that like a LASIK flap or like a PRK? You take it off?
More like a PRK.
Okay.
It's your technique of choice, whether with a blunt instrument, plus or minus alcohol.
Got it.
But however you like, remove the epithelium, soak the cornea with the riboflavin solution for 30 minutes. You have to sit there patiently and put the drop every couple minutes. And then after the 30 minutes of soaking, then you can apply the laser, the UV energy for another 30 minutes. And then typically it's followed by placing a bandage contact lens, and then carry on with the post-op regimen.
Wow.
Yeah. It's not an efficient OR journey, but profound impact on pediatric eyes in terms of if you have mild keratoconus changes, to have the hope to slow that down or halt.
But painful too for kids, huh?
Yeah, good point. So the most common setting for this procedure in our country is probably in the office, awake. But in kids, that's often not feasible.
Right.
I have done it awake in the procedure room for a really mature, calm, cooperative 15 or 16-year-old.
Mm-hmm.
But certainly the younger they are, or sometimes not even about age, it can be challenging. So there has to be a flexibility of modifying the technique for younger kids, or even adults who might have some form of developmental delay, for example.
Mm-hmm.
The most obvious being, oftentimes you have to use general anesthesia, and not every center in the country can offer that. So we do get referrals for that indication. At our American Academy of Pediatric Ophthalmology and Strabismus meeting last month, there was a poster that described removing less of the corneal epithelium, because standard is to remove about 8 or 9 millimeter diameter area. But obviously that heals, it takes at least a few days to heal, and there could be delayed healing or complications or infections, especially in kids or developmentally delayed adults who might not be able to follow the protocol pristinely. And so this one poster suggested that you could remove a smaller diameter area just over the cone. And there's variations in how you can remove the epithelium, as I shared earlier. Anecdotally, maybe not using alcohol could be a little bit less painful. Sometimes I use a collagen shield instead of a standard bandage contact lens. It's basically just a dissolvable contact lens, so that in a situation where I don't think I'll be able to get near the eye post-op to remove a contact lens, at least this will serve as a bandage for 2 or 3 days or however long it'll stay in place.
Yeah, smart.
I'll often use a block, like a subtenon's block, for perioperative comfort. In adults, the standard is to, put a bandage contact lens in and start the drops right away. In select cases, I'll patch the eye after surgery for the first night until I see them post-op day 1 for a little comfort there. I haven't done this myself, but some groups have advocated for placing a temporary tarsorrhaphy.
Sure.
And certainly judicious use of eye shields, goggles. Someone even said, a parent said a hockey helmet here in the Midwest. Arm restraints, if feasible, or on board, if the parents are on board with that, can all be tried. But these are tough cases. Younger they are, or if they're combative or scared, certainly it can make the perioperative care a little hairy. We all get a little anxious about it, and yet there's such a big draw to want to help these patients as well that we're willing to try whatever it takes.
Yeah.
And are typically in the pediatric population, a bilateral procedure is done when you have them under general anesthesia, or is it a stage procedure one at a time?
In the community, it's more common to stage the procedure, but certainly if it's a child they have to place under general anesthesia, I will lean more towards doing it bilaterally for the anesthesia exposure.
Yep.
And another benefit is, since we're specifically talking about the Dresden protocol, the 30 minutes soaking, 30 minutes treating, you can shave about 30 minutes off the time by treating the first eye while the second eye is soaking. You can have a little overlap there.
Mm-hmm.
So that's helpful too.
Yeah.
Makes sense.
And there are centers or locations internationally, especially, that talk about doing complete epi-on, so not taking the epithelium off altogether, or other types of protocols. What's on the horizon that might help this be more a safer, more tolerable, and hopefully just a successful procedure?
Yeah, you're right. Although at this current moment in time we only have the one option here in the U.S., there are many different protocols that have been used in other places, including epi-on protocols. So the difference mainly being you can skip the corneal epithelial removal step for obvious benefits. It's saves time, it's less painful, faster recovery, and even with removing the corneal epithelium, that might not be entirely benign. There could be associated corneal haze, which oftentimes clears with some patients and maybe some medications, but epi-on offers benefits in those regards. Now, some studies suggest that it may not be as effective, while others beg to differ. I think we're still learning about that. So in the US, there's 2 groups that are active in this space right now. Glaukos finished their phase 3 trial in 2023 and have received a new drug application approval from the FDA, with plans to come to market tentatively within this year or next. There's another group called epi-on Therapeutics, and their product is EpiSmart, and they're currently undergoing a phase 3 trial. So it's exciting. We may hopefully have access to these protocols soon here in the U.S. But beyond just epi-on versus epi-off, there's other things out there too. There's accelerated protocols that are used in other countries that are much faster than our current 30 minutes pre-treat, 30 minutes treat. And that has to do with changing how much energy is applied. There's other novel approaches being studied, like a device that fits on the eye, almost like a contact lens. So it's on-eye crosslinking. There are groups that are developing crosslinking that could be done at the slit lamp, with the idea of trying to make this more mainstream, more accessible, lower the barriers of access. And then there's also nuances like there's restrictions on who can get the crosslinking. If your cornea is too thin, you may not be a candidate, but there's groups that develop that are developing protocols for thin and very thin corneas as well. And there are other even more novel approaches being studied, like eye drop therapy. Maybe there's a certain compound that can be given to the eye in drop form. And there has also been research reported of using oral riboflavin, and believe it or not, taking that high dose riboflavin and walking towards the sun and allowing some cross-linking that way. So there are a lot of interesting ideas being tried. Let's put it that way.
What an exciting time. I love it.
Yeah, I think it's profound, as you've so well articulated, how we've changed in our ability to care for these kids early. One plug I'll just share, and Eric has given feedback on this for our practice here at Mayo, is for anyone that has optometric and or ophthalmology colleagues in a referral network, it's really important that everyone's on the same page, such that if a patient is identified as having concerning features, their referral is expedited. They should not be put into the normal myope astigmatism progressive category and get brought in 4 to 6 months later. We're certainly aware as pediatric ophthalmologists that a delay of even a month or 2 months in a progressing keratoconus kid can have profound impact on the outcome or even the ability to treat if the cornea is getting too thin. So just in your practices, our encouragement would be communicate with shared guidelines, and if there is a child with concerning keratoconus features or refractive change, have an expedited referral process to get those kids cared for.
I think that's well put, because certainly we want to offer treatment for these patients before they have irreversible vision loss. And I'll even throw in there that I'm especially mindful of vulnerable populations, like those that may have some syndrome or developmental delay, because oftentimes these children can't say if they have any change in their vision. They're not able to adequately advocate for themselves, and so they might be missed. And so I'm thinking of a couple patients in the last few months that I've had the privilege to see where we were to make that diagnosis. And so that's been kind of at the forefront of my mind. Just keeping our antenna up for those that might benefit from our care.
It's so important.
Well, thank you as a colleague, a friend, an expert in this area to share with us your wisdom and help us care for kids.
Thanks for having me. It was a lot of fun.
You can find all episodes of the Mayo Clinic Ophthalmology podcast on our website.
Thank you for listening, and we definitely look forward to sharing more